right, well, thanks for having me. I think I represent the heart failure intermission or interlude for this conference, so thanks for having me and inviting me. So I'll try to be quick here. So we're going to talk today about septal reduction to myosin modulation, current care in obstructive hypertrophic cardiomyopathy. These are my disclosures. So the late, great Eugene Brunwald passed away, I think, in late April. And about 70 years ago, he described hypertrophic cardiomyopathy. And all of us take care of HCM patients. And that's because it's the most common monogenic cardiovascular disorder. It's an autosomal dominant pattern. So we see a lot of this, and we deal with patients, and all of us have patients with HCM. We know that over the last multiple decades, the mortality for HCM has decreased significantly with careful sort of risk stratification for sudden cardiac death. I won't get into the details, but if you look historically, in the 70s, HCM death rates were fairly reasonably high, and with ICD intervention, myectomy, heart transplantation, we've had a significant reduction in HCM mortality. If we look at HCM phenotypes, we have multiple patterns that all of us look at via echo, MRI, and other imaging modalities. But what we wanted to concentrate on today was left ventricular outflow tract obstruction, obstructive HCM. And so we know with LVOT obstruction, we've got hypertrophic and anteriorized papillary muscles, slack and redundant chordae. In addition to that, displacement of the mitral leaflet coaptation points to the left ventricular outflow tract. We have traditional medical therapies for obstructive HCM. That includes beta blockers, calcium channel blockers, disopyramide. Now we have cardiac myosin inhibitors, and we just talked about AFib, so warfarin for any atrial fibrillation that's out there. We also have septal reduction therapy, SRT, that includes alcohol septal ablation, as well as myectomy, and we'll concentrate on this. With myectomy, this takes careful precision from a surgeon that has a lot of experience, and we'll talk more about this in a second. So current treatment pathways include oral beta blockers for symptoms that persist, a switch to calcium channel blockers, followed by consideration of disopyramide. And then the current guidelines suggest adding a cardiac myosin inhibitor in persistent symptomatic patients. And then if these symptoms persist, then evaluate for septal reduction therapy, or SRT, that can be done via myectomy or alcohol septal reduction, alcohol septal ablation. So let's concentrate on medical therapy first. So if we look at symptomatic HCM, historical medications, actually the data, there's been a paucity of data on these medications that we use. We've got beta blockers, and if we look at all the trials that are there, very small number of patients, non-randomized case series, and then really the only randomized double-blind placebo-controlled crossover trial was this one, which is the TEMPO trial, which had about 29 patients, published in 2021. And in these patients, the LVOT gradient was lower with metoprolol. Similarly, calcium channel blockers have a limited data associated with sort of the effectiveness for HCM, but we've been all using these therapies for multiple years. Disopyramide, in retrospective studies, has had improvement in gradients, but if you note at the bottom there, about 23% of patients have stopped in retrospective data due to side effects. So next comes cardiac myosin inhibitors. Without getting into details, really what they're trying to do is restore the normal equilibrium between actin-bound, sort of disordered relaxation sort of myosin proteins and auto-inhibited SRX myosin states. So really, at baseline, you've got normal sort of force generation, normal contractility, normal ATP expenditure. And then in untreated HCM, this shifts over where you have abnormal binding, increased ATP expenditure, and then all of this can lead to sort of maladaptive mechanisms of remodeling, fibrosis, etc. CMIs aim to restore that normal state. And so let's talk about CMIs and their clinical trials. If we look at it, it's an interesting sort of backstory between myocardia eventually getting bought out by Bristol-Myers Squibb, and then Cytokinetics, which worked with myocardia in developing some of these agents. But the initial trials started in 2020, or were published in 2020 with the Explorer-HCM trial. And this was a mavacamten trial that was a phase 3 trial that was published in Lancet that showed significant benefit of mavacamten on patients on background therapy for obstructive HCM. This was followed by another mavacamten trial called Valor-HCM that looked at patients who met criteria for SRT with a resting gradient greater than 30, Valsalva gradient greater than 50, and looked at SRT versus CMI, and after 16 weeks, how many of these patients still qualified for SRT if they went on CMI therapy. This was followed by a second generation sort of set of clinical trials using aficamten that has a little bit of different binding. And this was a Sequoia that was published in New England in 2024, as well as Maple-HCM. And then you've got two non-obstructive HCM trials, the Odyssey-HCM trial and Acacia-HCM trial. So Explorer met its primary endpoint, which was an improvement in peak VO2, and the number needed to treat was about 5 there. Complete response in hemodynamic gradients was seen in about 27% of the MAVA group versus 1% of the placebo group. And you had about 5% that had reduced EFs, less than 50% with mavacamten. We'll get into Valor in a second, but the number needed to treat here was 2, and specifically at 128 weeks, when you looked at their data, about 95% of all patients actually did not undergo septal reduction therapy, and this included those who crossed over to the actual therapy. Sequoia, which was just more recently published, showed improvements in peak VO2. The number needed to treat was about 1.6, and a decrease in EF less than 50 was seen in no patients. And we'll talk about Maple-HCM, which looked at a paradigm shift in HCM management, which looked at beta blockers versus aficamten. So this is the Sequoia trial. This showed an improvement in your peak VO2. Peak VO2 has been associated with outcomes in obstructive HCM. And this was the aficamten trial versus metoprolol trial called Maple-HCM. And I was fortunate to be on the steering committee for this trial, and we randomized 281 patients, screened 281 patients, 175 enrolled, aficamten versus metoprolol. In 24 weeks, looked at the primary endpoint, change in peak VO2, as well as a number of secondary endpoints. And really, aficamten won out, about 2.3 mils per kg per minute increase in your peak VO2 versus metoprolol, significant improvements in your gradients, whereas marginal improvements with the metoprolol. So talking about meds, what about myectomy, the gold standard for treating obstructive HCM? So I thank Srikanth for these trials, and we're looking at a patient on the left with obstructive HCM followed by TEE after myectomy. I have Dr. Livesay in the audience, and gave this grand rounds a few weeks ago, and this is sort of recent THI data looking at about 30 patients over the last few years or so. And among these patients, about age 54, you had significant reductions in your gradients and low operative risk, 0 mortality, low incidence of mitral valve replacement, low incidence of pacemaker placements with all of their surgeries that were done, 100% survival to discharge. So with myectomy, the key is, much like having, a Dr. Livesay, you need to have very good surgical support. The data on the left shows outcomes among low versus high volume centers. Obviously, high volume centers do better on the left, and then on the right, high volume centers have a reduced incidence of defibrillators, pacemakers, as well as other adverse outcomes. So we've teamed up. Shri has done a very nice job. This comes from Dr. Conru again, doing careful, precision-based surgical planning for these via echo, via CT scan. And our outcomes sort of mirror the Mayo Clinic data. And if you look at their data, you see that those patients who undergo myectomy and do well, they have a survival rate that's equivalent to the US population. So you're going to have long-term outcomes over 20 to 30 years that go very well with myectomy. And if you look at alcohol septal ablation versus septal myectomy, you'll see that this is, again, retrospective data from the Mayo that probably septal myectomy wins out over alcohol septal ablation. So getting back to Valor, we saw an improvement with medications. So when would you use medications versus sending a patient to a myectomy? And I think when you look at it, you need to look at what the patient really wants. So this is shared decision making, right? So you need to see that the patient has access to therapies, access to a good center, and the patient is ready for surgery. But in the meantime, we have a number of patients that have done very well with myosin inhibitors. So finally, the last two things I'll talk about are non-obstructive obstructive hypertrophic cardiomyopathy. And this is something we see quite a bit. They looked at this in two trials. The Odyssey HCM trial was published the same issue of New England. And this was a trial that looked at mavacamten for non-obstructive HCM. And this trial actually did not meet its primary endpoint in peak VO2 or KCCQ improvements. However, just recently, sort of the data came out last week, and we were part of the Acacia HCM trial in non-obstructive HCM. So aficamten actually met its primary endpoint, peak VO2 improvements, KCCQ improvements, and reductions in biomarkers as well, with adverse events that were similar between both groups. So we wait for that publication. So again, I think the paradigm shift now is in those patients with obstructive HCM, should we think about cardiac myosin inhibitors first? Probably so. They have a number of downstream effects, which we won't get into, that are on the right. But in careful, experienced hands, I think myectomy needs to be considered up front as well. So, and with myectomy, consider referral to an expert center. Thank you.